Hello, my name is Dr. Paige Armstrong, medical epidemiologist with the rickettsiosis branch at the CDC. I am also an emergency medicine physician. Today, I'm going to discuss RMSF and provide information to help frontline healthcare providers recognize and treat this rapidly progressive, fatal disease. Rocky Mountain Spotted Fever, or RMSF, is the most severe rickettsiosis in the United States, with mortality rates as high as 25% in untreated cases. RMSF poses a diagnostic challenge for providers because early symptoms are often similar to other febrile illnesses, and yet decision to treat is based on clinical diagnosis. The sudden onset of fever and headache at the beginning of illness prompts most people to visit a healthcare provider in the first few days of symptoms. Since most deaths occur within the first 8 days of illness, clinical consideration and early treatment during these initial encounters are critical to prevent severe disease and death. The most important thing frontline providers can do is to keep RMSF in the differential, because if you're not thinking about it, you will miss it. Here are the key clinical messages every provider should know about RMSF. It's a rapidly progressing tick-borne disease with nonspecific clinical findings during early illness. Doxycycline is the drug of choice for treating people of all ages. Treatment is most effective at preventing death and severe disease when started within the first 5 days of symptoms. And never wait for the rash to begin treatment. RMSF is caused by infection with Rickettsia rickettsii, an obligate intracellular bacterium, transmitted through the bite of an infected tick. It is spread by at least 3 species of ticks in the United States, including the American dog tick, the Rocky Mountain wood tick, and in parts of the southwestern United States and Mexico, the brown dog tick. RMSF cases occur throughout the United States, but are most commonly reported from North Carolina, Tennessee, Missouri, Arkansas, and Oklahoma. The first manifestations of RMSF begin 3 to 12 days after the bite of an infected tick. However, about half of all affected people don't report a tick bite. Initial symptoms include abrupt onset of high fever, headache, myalgia, and malaise. Children with RMSF are less likely to report a headache than adults, but more likely to experience periorbital edema or edema involving the dorsum of the hands. If laboratory tests are performed, white blood cell count, platelets, and electrolytes tend to fall within normal limits during early illness. By days 2 through 4 of clinical illness, symptoms will often include abdominal pain, nausea, vomiting, cough, rash, and worsening myalgia. Laboratory diagnostics may show elevated hepatic transaminases or mild thrombocytopenia. A classic case of RMSF involves a rash that appears 2 to 4 days after the onset of fever, as small, flat, pink macules on the wrists, forearms, ankles, and spreads to include the trunk and sometimes the palms and soles. While most patients develop a rash during the course of the illness, less than 50% of patients have a rash during the first 3 days, when most first seek medical care. In fact, late onset rash is a risk factor for fatal outcome. So the clinician should never wait for a rash to appear to treat for RMSF. Doxycycline is the treatment of choice for RMSF in all age groups. It's most effective at preventing severe disease if administered within the first 5 days of illness. The use of antibiotics other than doxycycline is associated with a higher risk of fatality. Doxycycline has not been shown to cause tooth staining in children when used in the dose and duration recommended for RMSF. Minimum treatment duration is 5 to 7 days, or at least 3 days after fever subsides and until there is evidence of clinical improvement. If treatment is not initiated and the disease is allowed to progress, days 5 through 7 of illness are characterized by high fever, worsening abdominal pain, which can mimic acute appendicitis or cholecystitis, and worsening respiratory status. The rash becomes petechial and more widespread. These symptoms are a reflection of the widespread vasculitis caused by R. rickettsia. Laboratory tests around days 5 to 7 reflect worsening thrombocytopenia, elevated hepatic transaminases, and electrolyte abnormalities, such as hyponatremia. Beyond day 7 of illness, irreversible damage to vascular endothelium leads to diffuse purpura, necrosis of digits, septic shock, renal failure, pulmonary edema, cerebral edema, altered mental status, and coma. People who survive can experience severe sequela, such as necrosis necessitating amputation, persistent neurologic deficits, and permanent organ damage. The most frequently used method for confirmation is serology, which measures the immune response and requires a 4-fold or greater rise in IgG antibody titer between acute and convalescent phase sera. Acute serum samples should be taken in the first week of illness or while exhibiting symptoms, and the convalescent 2 to 4 weeks later. A single serology result cannot confirm RMSF infection. Polymerase chain reaction, or PCR assays, are also used to detect R. rickettsia in whole blood or tissue during the first week of illness. Positive PCR results indicate the presence of R. rickettsia in the sample. Rickettsia circulate in low numbers in the bloodstream early in infection. A negative PCR test in the first few days of illness may not definitively rule out infection. Because RMSF can progress rapidly to severe illness, the decision to treat should be based on clinical suspicion. Prophylactic use of doxycycline following tick bites is not recommended to prevent RMSF and may confound or delay presentation, making it more difficult to diagnose correctly. It's true that RMSF can pose a diagnostic dilemma. However, there are things that can help guide clinical decisions. Number 1, assess for risk factors. Was the person exposed to ticks? Are they around dogs? Have they been to an endemic area? Number 2, look for red flags, persistent high fever, subtle laboratory abnormalities, failed initial treatment, patient appears toxic or unwell. Remember, this is a widespread vasculitis, so patients usually feel ill. Number 3, treat based on level of clinical suspicion. Even if you decide not to treat initially, consider next-day follow-up and educate patients or caretakers about the symptoms to watch for and the importance of returning for care. Thank you for your time and attention. Please share this knowledge with other providers and your patients.